Okay, so you should see my whole screen right now, which is fine. Okay, so today we're covering a different topic, and this is where I've been saying since the beginning of the semester, I'm much more excited about getting into this chapter and throughout the rest of the semester because now we're specifically talking about what psychological disorders do we mostly treat in childhood? What does it look like when we have more adult prevalent disorders, but we see it in teens or maybe even younger as well? And so what do we think about it? What do we think? So by me, I'm saying like the field, what do we imagine is like the etiology for some of these mental health conditions? Is there any like neurobiological correlate that we think is related to the disorder or the onset of the disorder? What are some of the risk factors and protective factors for developing this disorder? And then what are some of the treatments? So what are the types of things we would be doing when we treat this particular disorder? Are there differences by age? And of course, whatever treatment was developed, there's a theoretical model in the back of their mind. So what is the model that we're using to treat a specific disorder and why? Is it that we are using behaviorism and that's why we're treating a specific disorder? Is there some other theoretical orientation that we're using to guide our practice? So each disorder or class of disorders that we're going to talk about will have its own own set of etiological reasons, its course, onset, and treatment that we'll talk about. Okay, so today and Friday, which we'll talk about in a sec, is all going to be geared towards attention deficit or hyperactivity disorder, so ADHD. Just some reminders. Oh, yes, I see a hand. Go ahead.
Hi, I just had a quick question.
Sure.
I'm not able to access the PowerPoint or the slides. Are they published on our end?
Not yet. Yeah, not
Okay,
yet.
thank
Good
you.
question. Sorry, I usually like to have it up for you guys, but I made some changes last night. So
Okay,
I will
makes
get it
sense.
up for you all, yeah, right after class. Okay, so take good notes and then, yeah, I'll put the slides back up. Okay, so just review for this week, just important announcements. Reminder, like I just said, we're going over chapter 10, ADHD. I think I made a mistake and put chapter 9 here. I'm going to change that. So it should be chapter 10. Where are we? We're here today at Wednesday. You all already took the exam. I didn't have any questions from you all, which makes it, to me, sounds like it went okay. The TA and I looked at some of the quiz statistics already, and it looked pretty good. I think like all of you took the exam, which has never happened. So good job. That means you're all going to give yourself all 3 opportunities, which is the best place to be in. So yeah, Monday we did the exam. Didn't sound like there were any issues. Today we're talking about ADHD. And then Friday, just a reminder, we're still talking about ADHD, but we're not meeting. So we're doing a flipped classroom. So remember, that's where you watch the slides, you read your readings, you can see the PowerPoint that's been posted from last semester. So using your class time wisely. And then when we meet the next time, I'll start with questions from the flipped classroom day. So as a reminder, Friday, we're not meeting, it's flipped classroom. Second announcement. So next Monday, if you noticed in the syllabus, we had a placeholder for when to have a guest lecture. It was going to be Friday, the 14th, Valentine's Day, which is next week. Our guest lecturer had a better time in her schedule, which was Monday. So we're just flipping the days. So Monday, so Friday you have a class around. Monday, I will not see you, but you will come and meet still because you're going to meet with our guest speaker. This is one of my close friends in my cohort. So she is a student as well in the clinical psych PhD program. I asked her to come guest lecture for this particular section because her area of research in particular is working with externalizing disorders. So things like disruptive behavior disorders, conduct disorder, oppositional defiance disorder. And she primarily works with younger kids. So I think like her research interest is preschool kids. So this is really her bread and butter. And then clinically, which I think is really interesting, and I'm hoping she'll talk about it, just to give you all some ideas about what to do if you're interested in psychology and what you can do with it. So her interest in particular is more of a forensic lens. So she clinically works with juveniles who've been in the justice system. She does a lot of assessment. And so her primary interest is really that preschool aged up to adolescent age, really looking at conduct disorder and kind of where it detracts for some kids and why they end up in juvenile detention centers. So I think her interests are really interesting, and also just good for y'all to see what this research and what we're reading about in the textbook and talking about in class, how that translates to a clinical work position. Okay, I see a hand. Go ahead.
Hi, sorry. So she might answer this, but is it common for preschoolers to end up in juvie?
Yeah, she will answer that. That's like, no, there's not like a one-to-one, like, yeah, it's really common. It's not. There are specific risk factors that usually happen along the way, and there are specific things that you see. So if you see like a 3 to 5 year old there, where you're starting to see like oppositional defiant problems, that's not to say like, oh, when they're 13, they're going to end up in juvenile detention center and then end up in prison for the rest of their life. That's not the case. And I think parents, I think, get really scared when they think that, oh my gosh, my child was already diagnosed with ODD. That means they're going to end up on the wrong track. That's not necessarily true. I think there are certain intervention factors to help with that. And the other thing to think about too, and this is why this is a good class to talk about it, is we think about developmental psychopathology. So remember in that model with the different boxes, if your child is like 3 to 5, like demonstrating some conducty type problems, is it like developmentally appropriate? Probably not if they're getting like this diagnosis or if they're getting flagged. But along development, once they go to school, once they're socializing more, a lot of times it falls away for certain kids. So thinking about it too in the model, like it's very common for kids to grow out of it or for parents to intervene a certain way. So the long and the short of it is, yes, I've heard that. It's not that it's impossible. It's not that kids, it's not like you don't see that preschoolers ending up on the developmental trajectory to end up in a bad position in adolescence, but it's not like a given. It's not like, oh my gosh, you were diagnosed at 3. I can fortune tell and I know you're going to be in juvie as a teen. That's my broad answer. I think Shira will answer more specifically. And I think especially because that's her research interest, is like looking at little kids and then actually working with some kids clinically. And I think a lot of them will say, just in my experience talking to her, I know that she was working with these teens in these juvenile detention centers and mainly assessing like fit. And I don't know if it was competency, but I think it was like, actually, maybe it was competency. I'm not sure. But the assessment that she was doing was to try to determine, should they be released, or like, can we make recommendations so that they can be released to their family, or if not to their family, like somewhere else. And I know that in doing those assessments, I think there were certain things that seemed very common among these kids where they would say like, yeah, this thing happened like a long time ago, and many kids were reporting the same thing. So I think there are similar risk factors, but even then, if you have a risk factor, that doesn't mean you develop a conduct disorder and you end up in juvie. Yeah, but good question. I feel like that's a very common thing that I hear. And hopefully she can answer more. Okay. Yeah, so guest lecture on Monday, please attend, especially if you're interested in more of like forensic juvenile settings. She's a really good person to talk to. Okay. So keeping in mind, we only meet today, not Friday. You do come on Monday, and then you and I will meet Wednesday of next week. Okay, so we're obviously not going to get through all of this PowerPoint, and that's on purpose so that we have more to discuss on Friday when you're all reading it on your own. So the way we're primarily going to break up ADHD and even other mental health disorders as we continue along is looking at like, where does it fall in the DSM? So remember, that's our diagnostic statistical manual. So there's different like classifications in the DSM and then specific disorders that fall within that. So ADHD in particular falls within the neurodevelopmental disorders section of the DSM. So it's alongside with other neurodevelopmental problems. Some things just colloquially to remember is that there have been other terms that have been used to describe ADHD in the past. So hyperkinesis, hyperkinetic syndrome, hyperactive child syndrome. Those were kind of like many, many decades ago what things were being called. More commonly, I think people will refer to ADHD as ADD with or without hyperactivity. ADD is no longer in the DSM. So DSM 4, which was prior to 2013, I think had ADD in it. I think by 2014 or 2013 when we moved forward with the DSM-5, I think now we've all been using ADHD. So I think something that's common is someone would have been diagnosed 2005, for example, way before the DSM-5 came out. So they might have had a diagnosis of ADD, and so they will still refer to it as ADD. If they were to get reassessed using the current DSM-5, they would likely fall still under ADHD, and then depending on what the particular presentation looks like, which type they have. So yeah, ADD, same thing. It's ADHD nowadays in DSM-5 terms. I put this on here because so in our program, the clinical psychology PhD program, you do your coursework your first year, then your second year is half of your time is really doing clinical work. You're getting started. And so we do our clinical work through our internal practicum. So it's basically like a clinic on site in UH. And so where I did mine is at the FCC, the Family Care Center. And my supervisor worked primarily with ADHD and disruptive behavior disorders. And so my entire second year practicum was primarily doing this kind of work. And this was a questionnaire he would often give parents before we would start treatment. It was just to get a sense of what do parents know about ADHD, or are there any like myths that they have about ADHD. So I'm gonna let you guys look at this, see how well you know or you think you know ADHD. So this first one, and I'll give you the right answer. Okay, but this first one, ADHD can be caused by poor parenting practices. True or false? What do we think?
False.
False. Okay, good. False. What about number 2? ADHD can often be caused by sugar or food additives. Keyword being often.
False.
False. Yeah. Children with ADHD are born with biological vulnerabilities toward inattention and poor self-control. We think it's false.
True, I think.
True. Okay. Yeah, we'll talk about it and how we also add how we tell parents for the first time out if their child has been diagnosed. Okay, a child can be appropriately labeled as having ADHD and not necessarily present as overactive.
True.
True. Yeah.
True.
Yeah. You guys know a lot already. Okay. Children with ADHD need a quiet, sterile environment in order to concentrate on tasks.
False.
Yeah.
False.
Yeah, not necessarily, exactly. So yeah, that would be false. Number 6, children with ADHD misbehave primarily because they don't want to follow rules or complete assignments.
False.
False.
Yeah, good job. Number 7, the inattention of children with ADHD is not primarily a consequence of defiance, oppositionality, and an unwillingness to please others.
True.
Exactly. Yeah, it's not just, I think a lot of times people get frustrated, especially with little kids in classrooms with ADHD, and they assume you're trying to be defiant, like you just don't want to listen, and that's not true. Okay, number 8, ADHD is a medical disorder that can only be treated with medication.
False.
False.
Yeah. Good answer and exactly true. Okay, number 9, children with ADHD could do better if they would only try harder.
False.
Yeah, it makes me very sad to hear. And number 10, most children with ADHD outgrow their disorder and are normal as adults.
False.
False.
False. Yeah, so that is a tricky one. Yeah, it's a chronic disorder, and at the same time, you can function as a normal adult. So let's see what our questionnaire actually says. Yeah, number 10 is false, and I think it's exactly because they don't actually grow out of it. We think of it as a chronic condition, but it can be really well managed.
I was
Okay.
going to ask if
Yeah.
that's what it felt like a gray area question to me, because do they outgrow it or do they just develop coping skills?
Yeah, to me, this was like also a gray area. That's why I said like kind of sometimes. I also agree it's a gray area because the way we diagnose ADHD, we conceptualize it as a chronic disorder. So like if you think of medically, if you have any like autoimmune issues, usually that tends to be chronic, but we can manage it and we can bring it down to like normative levels, but it's very common for it to like go up and down. So I think with ADHD the same. It's not necessarily that they'll grow it. It's just that there's probably a lot of good intervening factors, whether it's medication or like coping mechanisms, like you said, or even what we would do in treatment is really work with the parent to manage parenting behaviors to better equip the child with ADHD. So yeah, it's like it's how many intervening factors do you have at the beginning when you're first diagnosed to then set them up for a normal life where you can cope better. Um, so I mean, I can say too, imagine I worked with I think she's 27-year-old who clearly has ADHD, also had ADHD in childhood, um, was well managed throughout school, I think because she was on medication. And then when she turned 18, I think she moved out of the house, found it very difficult to find a psychiatrist. She was on and off health insurance. And so by the time I saw her at like 27, yeah, it was not well managed. So I thought that was a good example of like it is a very chronic thing, and you can go up and down in different windows of tolerance. Okay, we got our next set of questions. And this is the last set. So ADHD can be inherited.
True.
So there's some genetic risk factor. 12, ADHD occurs equally as often in girls as it does in boys.
False.
Yeah, I really don't like this question, and we'll talk more. It's like a question of in nature, is it actually occurring at an equal rate, or is it just about diagnosis? Is it that one group gets diagnosed more? 13, ADHD occurs more in minority groups than in Caucasian groups.
I don't know about this one.
Yeah, to be honest, I don't remember. Okay, just off the top of my head, I've answered this many times, of course. I think that different cultures, I think, especially when we think of like obedience, saying like well managed, I think they present sometimes at lower rates than American groups. So just in private practice or even at the FCC, you saw predominantly white American families coming in, whereas we saw lower rates of minority groups coming in just for referral. I think a lot of times probably because of like some stigma about coming into the practice to get help for psych problems. So I'm gonna say, okay, but let's see what it says, if it's true or false. Okay, 14, if medication is prescribed, educational interventions are often unnecessary.
False.
Yeah, exactly. It's because it's not just a medical condition. We need to impact the environment to set the child up for success. 15, if a child can get excellent grades one day and awful grades the next, then he must not have ADHD.
False.
Yep. Can wax and wane. 16, diets are usually not helpful in treating most children with ADHD.
False.
I think so too. I think there's more research coming out about like how does our diet impact us? And I think it certainly does, but I think there's still like not a consensus in the field about how much do our foods that we eat impact our body in terms of our mental health. So I will say I think there's research trying to challenge this and say that yes, our diets do matter. There's obviously conversation about certain like chemicals and dyes, and people think that it raises your risk factor for developing ADHD. I don't know if that's true. I think there's more research that's needed, but I'm just adding that I think there is conversation about paying attention to diet and if that impacts mental health, especially in kids. Okay, 17. If a child can play Nintendo for hours, he probably does not have ADHD.
False.
False. And 18, children with ADHD have a high risk for becoming delinquent as teenagers. This is someone else's
Would that
question.
be true, maybe?
So I think
Because I was just thinking about like ADHD, kids with ADHD have issues with controlling their impulsive behaviors.
Yeah, it's really hard to say because I think I'm assuming there are positive parenting factors in there to remedy the impulsivity and that there's treatment. But yeah, like, okay, so for example, I'm going to give a different disorder. So ADHD in kids is commonly associated also with like anxiety. If you think of little girls or boys too who've been like in school, they get yelled at a lot for being off the wall. So I think it is very common to develop internalizing disorders. And yeah, I guess the risk is really high for boys with ADHD to also develop like substance use disorder in adulthood. Mm, I feel 50-50 about this one, and I guess we will see. But yeah, I hear what you're saying. And I've clinically seen that as well. Okay, that one seems gray area. Let's see if it's true or false. 19, children with ADHD typically are better behaved in one-to-one interactions than a group situation.
True.
True. Yeah, I think if we think of impulsivity and executive functioning, which is like our air traffic controller in our brain, as being kind of sensitive to noise and distractions, I would imagine that, yeah, sometimes one to one. I think the caveat is that that doesn't mean then that we silo a child and that they can only be alone, because that will be damaging to their social development. And 20, ADHD often results from a chaotic, dysfunctional family life.
False.
Yeah, I think we certainly think there are parenting factors, especially with little kids, that can be improved, and but it's not necessarily that they have a chaotic, dysfunctional life. Okay, let's see our answers. So true, ADHD can be inherited. Yes. The thing I'll say as a caveat is that it's not necessarily a one-to-one. Like just because I have ADHD, my child will end up with it. I think the risk factor is high. There is strong genetic risk factor, heritability. Does it occur as equally in girls and boys? This is the thing where I said that there's a question in the field of like, is this like in nature actually as it occurs? Like, is it actually equal, or is it that we diagnose at higher rates? And I think still, even then, we would say it is higher in boys than girls. ADHD occurs more in minority groups than Caucasian groups. We say that's false. To me, it's the same question of in nature, does it occur at equal rates across cultures, across genders, across age, or is it more of a diagnostic issue? I don't know. I think to me, it's more about like referral question. Like we see fewer minority groups coming into therapy for many different reasons, whether it's alternative medicine, different beliefs, or even stigma to come receive treatment. Medication is prescribed, educational interventions are often unnecessary. Very false, because it's not just about medically what's happening inside our body. That will treat like some of the like sensitivities in our brain, but it's really about the environment too. So we want to ensure the environment, whether you're at school or at home, is really set up to help the child succeed. So educational interventions would include things like having a 504 plan, which is we'll talk more about that, but within a 504 plan, determining like what are the specific accommodations a child might need so that they can succeed as equally as well as another child without a disability. So that might include, so then you have an IEP plan, or IEP meeting, and you might determine, okay, this child has ADHD. How do we even it out? If we think of this as more of like a disability, maybe the child needs to sit up closer in the class. Maybe they get preferential seating in the front. Maybe they get like brain breaks, like they get to stand up a little bit more. So different things in the classroom that we can do to help better accommodate this child to succeed. Okay, 15, if a child can get excellent grades one day and awful grades the next, then they must not, I'm going to say have ADHD. We are not our disorder. So I'm not going to say he is ADHD. Yeah, false. There are many things that can impact us on a day-to-day, and especially a child with a particular mental health disorder. Okay, 16. So this is the one that I said was like, there's a lot of conversation in the field. So diets are usually not helpful in treating most children with ADHD. Yeah, usually we don't really go to the nutrition side. In psychology, we really focus on what is the behavioral treatment for that? How do we help parents feel less stressed about their children? How do we ensure the child has very clear boundaries, expectations from the parent? So in psychology, we go to treating the behavior in the family system. Our first line is not to go to the diet. If a child can play Nintendo for hours, he probably does not have ADHD. Yeah, that's also false. That's a common, I think, misconception I've heard among parents is, well, I told him to do chores, or like, I don't understand why he won't sit down and do homework. He can like sit down and watch his iPad for 3 hours until I take it away. And I think very common among kids. And that's also actually indicative of the opposite, that like, yeah, they can engage in preferential activities, but it's when we get challenged and, maybe our attention isn't on the other activity that it's really hard to task shift. So I think there are things in place that a parent can do to help better orient the child to move on to the next activity, the preferred activity from the parent's perspective. Okay, children with ADHD have high risk for becoming delinquent as teenagers. This was our conversation earlier that I'm like, oh, it's a gray area because yes, numbers wise, we think that they're at higher risk. That doesn't necessarily translate to yes, they always end up with delinquency. I don't like that word delinquency. But yeah, we especially in boys tend to think that if you have ADHD, you're at higher risk for more of these externalizing behaviors like oppositional defiance or especially substance use and even like risky behaviors. We kind of think of that more often in teenage years because that is coupled with being a teenager where your brain is like going through more brain maturation. Like there are a lot of changes in adolescence to your brain. And so when you already have ADHD, poor impulse control, poor executive dysfunction, when you're in a situation where anyways, all teenagers are kind of tested with impulsivity, being safe, it puts them at a higher risk. So we have higher rates, I think, of like brain injuries from like car accidents in children with ADHD, especially boys, higher rates of substance use. But I will say that doesn't necessarily mean ending up uh, in a justice system, like not necessarily ending up in juvie or like prison later on. Okay, children are better behaved usually in one-to-one interactions than in a group situation. Yeah, it's usually helpful when you have less stimulus, less interaction with multiple people. So those would serve as distractions. And the caveat too is that that doesn't mean then that they should be isolated. And then often ADHD can result from a chaotic, dysfunctional family life. False, yeah, it can happen in any family system, but yes, having a dysfunctional, like maybe not very clear rules or very clear interactions between the parent and child, that can make it more difficult. Okay, sorry, am I coughing a lot? Okay, so here is our diagnostic criteria in the DSM. So the DSM, we typically have like kind of the same last three criteria. So let's see, D and E for sure. So needing to have some sort of impairment, that is always something we have to look at. So that's almost always going to be in every mental health disorder you look at. That'll be somewhere in the criteria. And same thing with E. So the symptoms do not occur exclusively during the course of schizophrenia or another psychotic disorder and are not better explained by another mental disorder. So in general, what that means is we just want to be able to say like these symptoms of clusters that we're seeing, this behavior that we're seeing, we're going to say it's attributable to this disorder, not potentially some other thing happening, whether it's another mental health disorder or whether it's another medical disorder. So needing to try to really parse things out and be as certain as we can be, that's really what D and E is about. And I'll point out D is also about our three characteristics we talked about in chapter 1 about behavior is not necessarily harmful to the person unless it meets all these criteria. So is it messing with their social interactions, and is it messing with them at school? Are they upset about it? So different factors will impact our diagnosis. Okay, so A and B, or yeah, A and B are the most important. So A is where you commonly think of like, what does it look like? So ADHD criteria a persistent pattern of inattention and or hyperactivity / impulsivity that interferes with functioning or development. So that's the primary thing, and it needs to be characterized by either 0.1 or 0.2. So it can either be the inattention cluster or it can be the hyperactivity impulsivity cluster, or it can be both. So I think people sometimes confuse, well, if you don't have both, then you can't have ADHD. You don't have to have both. It's common to see both. But yeah, it can be one or the other too. So if you're going to have the inattention type that we're looking at, you need to have 6 or more of the following symptoms. So points A through I, and they need to have lasted for at least 6 months. And again, it needs to seem that it's developmentally inappropriate and it needs to have negative impairment in the child's life. So in any order, we can get A through I. So it can be failing to give close attention. So oftentimes you'll see they make a lot of mistakes, like messing up like their name or like a lot of mistakes in their homework. B, often having difficulty sustaining attention in tasks. So that's what we talked about earlier. Why is it that they can spend all this time doing something else, but then why are they inattentive in this particular task? Often seeming like they're not paying attention when spoken to directly. I saw this one a lot in my practicum. And in particular, I'm thinking of a child that really was one of these inattentive type of ADHD subtypes. And it was really like it seemed like he did not see that we were in the room, like really odd, like, did you know I'm next to you? Like, can you tell? Like, I'm right next to you. And he just would not seem to notice that we were talking to him because he was kind of like in his own little world. So I think that's often a flag for many parents is why is it that my child doesn't seem that he's listening to me? D, so often does not follow through on instructions and fails to finish schoolwork. So I think that task execution, so initiating the task and executing it from start to finish can be very hard. Difficulty organizing tasks and activities, avoiding things that require more sustained mental effort. So again, that's that example of why can my kid sit on the iPad for 3 hours, but I told him to go brush his teeth, and that's like really hard for him. Yeah, because that requires more sustained mental effort. Often loses things necessary for tasks or activities. So you'll often see like, oh my gosh, I can't find my pencil in my backpack, and maybe they don't have a pencil. So just a lot of disorganization and losing things that are necessary. And then becoming easily distracted by extraneous stimuli. We talked about that, and often becoming forgetful in daily activities. Okay, so that's our inattentive subtype. Hyperactivity and impulsivity is the next subtype. And again, you need 6 or more. So I'm going to go back to our conversation about categorical versus dimensional early on. This is this example of like, there are many different combinations of symptoms that you can endorse. When you need to have 6, that's actually kind of bit. I think there's 1, 2, 3, 4, 7, 8, 9. Okay, so 6 out of 9 is like kind of like most of them, but if you have to endorse like a little bit fewer, the combinations increase. So you can imagine that someone with one disorder who endorsed 6 out of the inattentive symptoms is going to look very different from someone else who endorsed a lot of the hyperactivity and there's no overlap with inattention. So I think this is one of the problems with the categorical models, that you can have a lot of heterogeneity within the same disorder. Many people can have a diagnosis of ADHD and look very different from one another or have very different experiences from one another. Okay, hyperactivity and impulsivity. So this is the one that I think like stereotypically is what I think teachers often consider ADHD or kind of flags their attention. So fidgeting, tapping your hands, leaving your seat, running or climbing situations that are inappropriate, being unable to play in a leisurely activity in a quiet manner, being on the go or like driven by a motor, talking a lot, blurting out before their turn, difficulty waiting her turn, and then interrupting or intruding on others. So that's kind of that like can't get a word in often when you're talking with this little kid. They're like up in the room. I remember my first, and Shira actually, who's going to be guest speaking, we had our first practicum together, and our first client was a joint client. So we saw the same kid, and our little kid was like up the walls, like literally climbing up on the computer desk. Like we were so scared to get her down because we were like, I don't think we can touch her, but we need to get her down because it's unsafe. But she was the kid that was literally off the walls, like jumping from wall to wall, jumping on it, like furniture, and was a very sweet kid, but just was very, very active. And I was only with her for 50 minutes, and I can imagine how difficult that probably is for the parent. In this case, the parent had a newborn baby, or no, she was pregnant, like very pregnant, and had like 3 other kids of her own. So you can imagine it can cause a lot of difficulty in the house and a lot of tension sometimes. Okay, and then B, several inattentive. So whatever the symptom is that you're going to be endorsing, I don't remember when this cropped up, but it needs to be present prior to age 12. So again, we think of this as like a chronic and it's neurodevelopmental. So we think that it needs to have some sort of onset in childhood and that it needs to be maintained over time. So like that adult client I was talking about who was 27 when I was seeing her, she definitely endorsed ADHD symptoms much before adulthood. So in childhood, I think probably in like the school age years, usually the school age years, like when you enter first grade, second grade, as the demand goes up, that's often when these kinds of kids get referred for a diagnosis or for treatment because we're seeing how impairing it is, especially at school. Okay, looking at our time. So given that you can have an inattentive subtype, or you can have the hyperactivity/impulsivity, or you can have both, you can then have different presentations or specifiers. So combined is the one that we have the most research on. This is the one where you meet both. You met criteria for both inattention and the criterion A, hyperactivity, impulsivity specifiers. So this means you met 12 plus symptoms. So remember, you have to have 6 in the first one and 6 in the other. If you're a combined presentation kid, you have 12 or more of those symptoms combined. Predominantly inattentive means you met criteria for the 6 for the inattention, but you did not necessarily meet all 6 for the hyperactivity and impulsivity. This serves as a problem too, because what if you definitely like experience the symptoms of hyperactivity and impulsivity, but you only could endorse 5 out of 6? That means you wouldn't get this predominantly you wouldn't get this combined presentation. You would still be labeled with this inattentive presentation. And same is true for the hyperactive/impulsive presentation. You meet criteria for one, but not the other, but that doesn't mean you did not endorse any. Okay, so we're going to talk a little bit more about like qualitatively what might we see in the different subtypes. So inattention, again, not being able to focus. And this is the kid that parents might complain about for playing on something for hours. Having trouble managing simultaneous stimuli or switching from one task to another. So again, it's difficult to initiate the task and then to switch your task. So that signals to us some difficulty in executive function. Having focus on unimportant information. So I think that one is funny, but has happened many times, feeling easily distracted. And the central problem is really control and self-regulation rather than simply inattention. That kid I was talking about where we would be in the room and it was like he did not know we were there, did not feel like he really tagged that we were talking to him. He was this sluggish cognitive tempo type, so very like slow and lethargic, seemed very socially withdrawn, so was very quiet and closed off, and like in his own world, which was really that inattentive type. But we added this sluggish cognitive tempo because of these other additional markers that were definitely sluggish cognitive tempo. Okay, hyperactivity and impulsivity. I'm not going to talk about this, but this is like your quintessential, what you imagine on TV, like just very active on the run. And again, this is as a child. So this can look different as you get older. So a teen may not necessarily look the same as a little 5-year-old with ADHD. But in young childhood, we really think of this type of stuff as the markers of impulsivity and hyperactivity. Okay, I think this is an important little graph, and it's also from your textbook. So, so with hyperactivity and impulsivity in particular, problematic activity level may be a larger problem in the afternoon. So if you imagine a little kid who, let's say they did take medication at the start of their morning, they went to school, they're managing, like kind of really on, like really modulating themselves, and then they get home, and then the rest of the day is kind of less structured. A lot of time, medication wears off by that point, and also activity level just increases for them. So a lot of times parents will say like, oh my God, they were good at school, but like when they got home and like their evening was terrible, like we could not manage. And it's really just that hump of behaviors and activity level really increasing and becoming more of a problem in the afternoon and evening. And then there's differences between non-ADHD and ADHD children in the afternoon. So if we look at this light blue, this is what it's like for them in the afternoon. So 210, And then if we have the kids with the combined type, and especially the inattentive type, you can see that it really skyrockets from here to here. So that even is the same if your child is taking medication. So you'll see this like wear off period, and in general, this afternoon period becomes more active for them. Okay, related features. So this is what we kind of talked about earlier too, and when we talked about like executive function and impulsivity. So not only are we diagnosing, like, are we thinking about the criteria that we saw in the DSM, but we're also generally thinking about some of these other features that tend to be related. So a lot of times motor skills tend to be impacted. So if you have, I think, like a little hyperactive kid who's like on the go, a lot of times there's like clumsiness, and that's not exactly a feature of the DSM, but it tends to be very common. So even seeing clumsiness in our motor skills might be a telltale sign to us that maybe some ADHD is going on here. Intelligence and academic achievement. So I will preface this by saying that having ADHD or any other like ODD or anything like that doesn't mean that you have low IQ or that you perform low. It just means that academic failure is often very common in kids with ADHD. So not necessarily failing a grade completely, but really needing some additional support. So needing accommodations, or maybe you're just having a really hard time paying attention in class, which is obviously what we would expect. So it is very common that their performance is much lower in school without having intervention. And then executive functioning is what we think is kind of like the air traffic controller in the brain that would be responsible for symptoms like ADHD. But with that comes all these other things that get impacted by poor executive functioning. So even emotion regulation. Again, emotion regulation was not necessarily a symptom in the DSM for ADHD, but it's very common to see kids become easily upset, getting really emotional, or having behavioral outbursts because of this additional like poor executive function. Okay, and then I think this is the last one on related features. So again, adaptive behavior. So that's more about your independent, like life living skills. So taking care of your teeth, or like putting your clothes on, keeping your room clean. A lot of those things get impacted in a in a like deficit type of way. Social behavior and relationships also can get impacted. And again, remember, especially when you're like 7 years old, you're in second grade. So being the kid, if I'm thinking about the hyperactive child, being a kid who gets yelled at by the teacher all day can have implications for their social relationships. Being a kid who interrupts their peers every time they talk in class can upset their peers and ultimately impact their social relationships. So it is very common that you see peer problems in child ADHD. And then peer and teacher relationships. So that's, again, we already talked about the peers, but again, it is very common to see kind of some tension with teachers, um, especially when it's not managed very well. But when there is some intervention going on, I think it improves a lot. And then, okay, health and sleep accidents. So I specifically want to talk about the accidents. So this was, again, that comment about impulsivity in adolescence and executive function that then becomes associated with higher risk activities you're engaging in. So driving really, really fast with no seatbelt on, that's impulsive. That's not really sorting through the cons, like the pros and the cons, really sorting through what my consequences could be. So it's very common that with low impulsivity, you end up in these sort of high risk situations where you can get hurt. So if you're having low executive function, poor impulsivity, like you would have in ADHD, you're at higher risk for some of these accidents. Okay, so we have like about 10 minutes. So we'll see how far we get, and then you can continue the rest later. So if we're thinking about poor impulsivity, some executive functioning issues, that really points to some neurobiological features. And so we think that the behavioral symptoms of ADHD tend to be linked pretty directly to executive function. And executive function, when we look at like brain studies and we're piecing apart the brain, it's really your prefrontal cortex. That's also why when we talk about adolescence, where that already is a developmental period with a lot of risk, that's because our prefrontal cortex is also still forming. And it's very sensitive at that point because we're just in a biological period that really is maturing again. So it's really like babies, like infancy, adolescence, and then 25, like that big, those three humps are when your brain really goes through a lot of changes. So if we were to look at functional and structural imaging studies, we would see a lot of differences in the brain in certain regions when we're comparing a child with ADHD to a community sample. A community sample is just referring to a sample from the community that generally probably has lower rates of any mental health problems. I'm not going to read all of this, but yeah, there's different ideas about brain volume being different, prefrontal lobe and striatal area being different, and then different abnormalities in certain structures of the brain. Okay, some co-occurring disorders. I think this is important because, again, this speaks to comorbidity, and that's a problem of the categorical system. But again, having ADHD tends to frequently co-occur with learning disabilities, so something like reading disabilities, or like dysgraphia, which are like writing problems. Autism tends to be highly associated with ADHD. And then, of course, externalizing disorders. ADHD we think of as more of an externalizing problem. So ODD, conduct disorder, internalizing problems. I gave that example of anxiety. So a lot of times getting very anxious about going to school or going to the park. And a lot of times it might be related to prior interactions. And then gender. So we talked about this already, but is it really nature, or is it in terms of diagnosis rates? In general, we will say that there are higher rates of conduct in ODD in males, and then higher rates of internalizing problems in females. Prevalence. So in general, right now, we're seeing about 5 to 9% of school age children. So school age children would be like first grade to like, I don't know, sixth grade. So before you're going into middle school. So that's 5 to 9% prevalence. And again, when you're getting yourself to school and you're a child with some of these more attention problems or inattention problems, these are the things that are typically getting flagged in a classroom. So it's usually going to class that these concerns that are raised by the teachers is what eventually gets back to the parent, and then the parent finally takes them in for evaluation. So ADHD and autism are one of the most, well, okay, ADHD, learning disorders, and autism are the most common behavioral referrals to healthcare professionals. I'm going to skip this, but again, look at the gender differences between boys and girls in terms of rates and then school settings. Okay, etiology. Again, if you think about our developmental psychopathology model, there are many different factors that we always have to account for when we're thinking about how someone develops a certain disorder. It's never just that there's a gene factor that therefore automatically means this person develops a disorder. It's always about the environment, the genes, and how those things interact. So we do have genetic influences. And again, we said there are stronger genetic factors when it comes to ADHD. So heritability rates would be about 0.8 to 0.9, which is very high. Again, we think there are biological correlates. So we already looked at different brain differences. We noticed that there's different brain volume, different structural differences. So again, there's no specific gene for ADHD, but there tends to be a lot of similarities across brains when we look at different people with ADHD. And then environmental risk factors that tend to be associated with ADHD are things like birth complications, getting exposed to illicit substances in utero. Diet does not appear to play a strong role in ADHD, but that's not to say it doesn't associate at all. Lead exposure. I think the most important thing here is the overly harsh or aggressive parenting practices. These more parent-child interactions are very, very important in ADHD, and especially in the maintenance of ADHD. So I think, okay, let's talk about the course, and I think we're going to get to treatment soon. So the course of ADHD, when we say course, we mean the developmental course. What is the trajectory? So again, ADHD is associated with poor long-term outcomes. This point here about mortality and morbidity rate, it's not that you're just going to drop and die someday. It's just that usually when we engage in more risky behaviors, that leads to a higher rate of death. And again, I mentioned substance abuse, especially in teenage years when you're already at risk of risky behavior. That's the period when we tend to see this happen more with kids with ADHD. So risky sexual behaviors, motor vehicle accidents, and just injuries. I'm not going to read this, but these are some examples of things that might look a little bit differently in terms of the developmental period the child is in, whether it's infancy, childhood, or adolescence moving toward adulthood. Okay, So then how do we look at ADHD? Like, how are we going to assess it when they're bringing us this child in this clinic? So number one, we will do a clinical interview. So we want to interview the parent. So tell me about what's been going on at home. Okay, you said your child is inattentive. Like, are there specific settings that seems to be happening in? So again, talking to the parents. Some people might also ask the teacher to get interviewed. So that might be a possibility. Direct observation is also important. So while I'm sitting in this waiting room talking to the child and the parent, or mainly to the parent, I'm also observing the child. So oftentimes, if the child's in the room with them, you're noticing as the clinician, okay, I'm seeing some markers of ADHD. Very common standardized cognitive tests that we give when we're assessing ADHD. So any of those neurodevelopmental, like learning disorders, ADHD, autism, we're often giving some sort of intelligence test just to see where they lie. Some other tests that we have, the CPT and the CATA, those are some attention difficulty assessments. So I've given these tests before, and it's basically like sitting at a computer with like little headphones on. And with the auditory test, you're listening to like a little sound boop into different ears. And you're seeing, I think, a dot on the screen, and you're supposed to like press the button when you hear it. And same thing with the performance test. And then questionnaires, we again often give self-report questionnaires, but if the child is too young, then we will not, and we'll just primarily get informant report. So again, for ADHD, we often will, of course, get the parents, but oftentimes we see teacher report too, if we can get it. Okay, so then I'm gonna leave us with a couple minutes to talk about treatment, and then you can read the rest. So what then is our treatment for ADHD? If there are some genetic, like neurobiological factors happening and a lot of the environment happening to this child. So there is psychopharmaceutical treatment, which would be medication. The thing I'll say here is that medication oftentimes tends to be like fast acting. So you give your child medication and it's a night and day difference. A lot of times that is true, but it's short acting. So it doesn't really change long-term benefits for the child. The way to impact long-term benefits or to set the child up for success for the long term is by psychosocial intervention. So it's really, again, with young kids, going to be about managing parenting behaviors for how to navigate working with a child with ADHD. So this is the thing, in combination is great, but really for long-term benefits is going to be parenting intervention. So we call it behavioral therapy. And again, this is because we're using behaviorism as our orientation. We care about improving or increasing the occurrence of positive behaviors. So we're working on reinforcement. We might be using some negative reinforcement, positive reinforcement. We're also considering consequence, whether it's positive or negative. So very rooted in behaviorism, but is mainly using the parent as the agent of change. So this is our umbrella of behavioral parent training. So that's like the umbrella term for working with the parent in order to then manage child's ADHD or disruptive behavior problems. So it's like a brand umbrella name, and then underneath that there are specific like interventions with different names, but they're all rooted in behavioral parent training. So positive parenting program over here, Triple P, there's a lot of research on positive parenting program, especially in the context of domestic violence. So the children of parents who have, used domestic violence against one another tends to have pretty high risks of child behavior problems and conduct problems. And so there's actually a lot of research on positive parenting program in that context. In general, they all share a few things in common. And that's that they have core elements to use the parents as the mechanism of change. So if we help the parent harness their relationship with their child, teach them some additional parenting, strategies that could be helpful, that's the thing that's going to impact their child in the long term. We're also, regardless of the specific name that you're using or intervention under the behavioral parent training umbrella, we're also working to increase attention on pro-social behaviors. So we want to improve their relationships with peers, improve their relationship with teachers, and remove attention from antisocial behaviors. So this is that idea of we give attention to the things we like, to the things we want to increase, to the things that we want the child to keep doing, and we remove our attention from the things that we don't want. So I'm not going to give attention if the kid is, trying to irritate me and is like putting their hand like on their mouth and making that sound, I'm not going to look at it. I'm not going to give it attention. They take their hand away. Oh, I love that you put your hand away. That I like hearing the silence or whatever. So I'm increasing attention for things I really want to go up in terms of frequency and occurrence, and I'm removing attention from things that I don't want to happen. And we're teaching the parents new parenting skills. So there's a lot of evidence to support the efficacy of ADHD, efficacy in terms of this type of parent training intervention. And it has even better impact on the child when it's combined with medication. So I think a lot of times parents may consider medication first because it feels like a fast acting thing. It's not as time consuming. You go to your doctor and you have a referral maybe, and they give you medication, and maybe you have like a 15-minute follow-up every now and then. It's not as much effort and time, definitely on the parents' part when you just do medication. So I will say it is a lot of work to be doing parent management training. But I think when you can commit the time, like that's the point where you're going to see the most beneficial outcomes for the child. Okay, I think let's end here. The rest of the slides, I think, let me see. Yeah, the rest of the slides. Oh, we're very close. So these are just the last two slides for what are some principles that we're actually teaching in parent management training, whatever the specific brand is. So how will we use negative consequence? How will we use parenting practices that are positive? So what are the different key elements? And then just a refresher on evidence-based treatments. Okay, wow, we got through most of it. Any questions about what's happening to Friday or Monday? Because we won't see each other for a while. I think so. Okay. Also, because Shira is going to be lecturing on Monday during our class period, I also am going to be out during that time. So I am not going to be available for office hours, but no one has come to the office hours, so I'm assuming no one will need anything. But if you are by chance going to come, just send me a message, and that way I can message you there and you don't have to come to the office hour. Okay? Okay. All right. Have a good rest of your week. I'll see you all in a couple of class periods. But yeah, please come to Shira's lecture. It's very interesting. It'll make her happy to see a lot of people there. Okay. Bye, everyone.